It's my pleasure today to introduce to you Brian Talon, who is a student in our graduate program. For those of you who don't know Brian, he's a graduate of our PharmD program here at UIC, and he started both the graduate program and a fellowship in 2016. He completed the fellowship last summer, right?
Yep.
And I don't know.
Dissertation time.
Yeah, and now he's moving forward to his dissertation pretty soon. But today he's going to be presenting something he's been working on for about a year and a half. It's an economic evaluation of clinical pharmacy services, a systematic review from 2011 to 2017. Thank you, Brian.
Thank you, everyone. So today my presentation is on the economic evaluation of clinical pharmacy service, systematic review from 2011 to 2017. So this was something that actually started one of my first projects as a fellow back in 2016, and it got delayed, so we had to add 2016 and 2017. And for that, I would like to thank my co-authors. So I've managed to rope in 3 generations of fellows into this project: Connie, Ali, Catherine, and now Bob. Okay, so let's begin. So my presentation today, I'm just going to give a brief history on the evolution of pharmacy practice, highlight some policies from the past 20 or so years that's helped the profession grow into what it is today. And then after that, I'm going to go into the actual systematic review in which we review all the economic evaluations that we found from 2011 to 2017. Okay, so this is kind of like the evolution of pharmacy practice condensed down into one slide. I had too many slides, and Dr. Tichette said I had to slim it down. So I'm going to start in the 1700s when Carl Wilhelm Scheele discovered oxygen. Yes, he discovered oxygen, even though we've been like kind of breathing it in the whole time. And he was kind of this pharmacist, chemist hybrid. And he also, at that time, discovered glycerin and nitroglycerin, which, of course, are still used today. 1816 in Germany, Friedrich Wilhelm Stirner discovers morphine, which is kind of a hot topic right now with all the research that we're doing. In 1890s, in France, Ernest Fourneau develops chemotherapy. In the early 1900s, in 1901, actually, Charles Walgreens opens his first pharmacy in the south side of Chicago. And then by the late 1920s, Charles Walgreens had opened about 529 pharmacies. So by the 1940s, with all the developments in drug discovery and the expansion of retail pharmacy, the pharmacy practice focused on compounding and counting and dispensing in the retail setting. And that's what pharmacy was known for in that era. And then entering the late 1950s and the early 1960s is when we see this movement towards more of a clinically and patient-focused area of practice. So in 1964, the University of Iowa institutes this unit dose service, in which they decentralize pharmacy from the basement and put them on the patient wards. In 1966, UCSF, so University of California, San Francisco, developed a 9th floor pharmacy project in which, again, they kind of take pharmacists out from the central pharmacy and allow them to make clinical interventions in the ward. And that project really led to what is today the modern day clinical pharmacist. And then in the 1970s and the 1980s, here at UIC, Richard Hutchinson and Herb Carlin build and establish our clinical pharmacy program here at UIC. And then throughout the 90s, the advent of the pharmaceutical era comes along. And with some policy developments in the mid-2000s, then pharmacy practice kind of moves into this new era of MTM. So I just wanted to highlight some policies that helped influence the practice of pharmacy in the U.S. So in 2003, the Medicare Prescription Drug and Improvement and Modernization Act required that Part D plans reimburse MTM providers, which does include pharmacists, and that's what led to our initial direction into MTM. In 2010, the ACA defined pharmacists as a key player in part of a team that's part of a patient-centered medical home, which is receives capitated payments from Medicare. 48 of 50 states now allow collaborative practice agreements between pharmacists and physicians. So in a collaborative practice agreement, the physician can delegate prescriptive authority and direct patient care to the pharmacist. And this varies from state to state. It's regulated at the state level. In Oregon and California, pharmacists are now allowed to prescribe short-acting hormonal contraception for women. And with the recent opioid epidemic, several states now allow prescribing of naloxone for opioid overdose by pharmacists. And one of the bread and butter interventions that we have is vaccination. And currently, in all 50 states, pharmacists have the authority to perform vaccinations, not just for flu, but for a host of other preventable diseases. So, that's great that we're expanding our services into different areas, different practice settings. But pharmacy services come at an additional cost to insurers and health systems, and we really need to establish the fact that we do provide benefits for those costs, because health systems and insurance, of course, want value for the services that they are paying for. So with that in mind, my aim is to describe and evaluate the quality of economic evaluations of clinical pharmacy services published between 2011 and 2017, and perhaps identify some trends in practice and most importantly, inform health systems and administrators as to their cost effectiveness. So specifically, we're going to assess the type and quality of different study designs utilized and also the type of economic evaluation. I'm going to describe the type of services provided and also the setting in which they're provided in, and also identify some trends and practices and compare it with prior systematic reviews. So this is actually part of a long-running series of systematic reviews, which started in 1988. So the first author there is now Dean Schumacher, who's in the back of the room. And then from then on, Glenn led the project, and then in 2001 and 2005, it was led by fellow alumnus of the program, Alexandra Perez, who is now faculty at Nova Southeastern in Florida. And then after Dr. Chet led the project, and for 2011 and 2017, the burden has fallen on me. Okay, so now on to the methods for the project. So we conducted a literature search for economic evaluations between 2011 and 2017. This is just an example of our search string. The databases that we use are pretty comprehensive, so Ovid, PubMed, IPA, Embase, and also CINAHL. We had 3 steps for the screening process, so title screening, abstract screening, and then manuscript screening. Each step was performed by a peer reviewer so that we could kind of just double check each other. So for the title screening process, we just wanted to know if the title mentions evaluation of some sort of pharmacist intervention. And then once we get to the abstract screening, then we can really kind of look deeper in whether this article was in fact evaluating some sort of clinical service delivered by pharmacists. And then once we received our pool of manuscripts, we then applied our inclusion and exclusion criteria, and we required that at this stage that both reviewers agree on whether an article is to be included. So what is a clinical pharmacy service? So the way we defined it was that it's a service provided by a pharmacist for a patient, caregiver, or provider that addresses some sort of patient-level issue, which could be economic outcome, clinical outcome, or humanistic outcome. If the article didn't evaluate cost or if economic outcomes were not measured, then that was excluded because then we couldn't kind of quantify what the economic benefit was. And what was particularly difficult is to separate out those that were team-based care. So, nowadays pharmacists, in the way we practice, it's very collaborative, and we have to exclude articles in which the entire team was evaluated, which included a pharmacist, but we couldn't separate out what the effect of the pharmacist was. Studies that used non-empirical data, was editorial or unoriginal reports, or some sort of narrative review was excluded. We also excluded systematic reviews, but we used them to Pearl for other resources. So data abstraction was performed by 2 reviewers onto REDCap and then downloaded onto Excel. If there are any discrepancies between reviewers, the inputs were collated, and then any discrepancies that were identified were discussed among the entire group. We abstracted a lot of data. I'm not going to go through this list, but they'll become evident in the results. So for each study that we included, we summarized the aim of the study using the PCOT framework. So I'm sure most of the grad students here have to be familiar with that. We also classified studies based on their study design, the type of clinical service provided, the setting of the intervention, and also the type of economic evaluation. So regarding the study design, we classified it according to several criteria. So the first one is whether a control group was used, yes or no. If a control group was used, was it a concurrent control group or a historical control group? And if there was a control group and it was concurrent, was randomization used? And if there was randomization at the cluster or individual level? And also if repeated observations were used, so multiple observations before the service at baseline and then after the intervention was implemented, we captured that aspect as well. So in terms of classifying the study design quality, we only based it on the design type only and not necessarily the specifics of the actual article. So high quality studies we define as, of course, the randomized studies. Of course, randomization balances our groups at baseline. But we also included some quasi-experimental designs. And what a quasi-experimental design is either no use of randomization or no presence of a control group. So in the high quality designs, in addition to experimental studies, we also included quasi-multi-group interrupted time series designs. And the reason why we included this is because these multiple observations pre-post, we could account for baseline trends and ensure that groups are comparable across time. Medium quality designs we defined as quasi-non-equivalent pre-test, post-test, so non-randomization and measures at baseline and after the intervention, and what's called a static group comparison where we don't have this baseline measurement. And these are classified as medium quality because, again, without randomization, there could be selection bias if patients select into the pharmacy group or usual care based on certain variables that could influence the outcome. Low quality designs, so if there were two groups and the comparator group or the usual care group was historical, we classified that as low quality. Just because of the different time periods, there could be other events that happen between those two groups that could influence the outcome. And of course, without the use of a control group, those are definitely low quality because then we can't really rule out other events that happen that could also influence the outcome. So this is the way that we've classified the study designs for these articles. And now I'm moving on to how do we classify the type of economic evaluation. And the way we classified it is not straightforward, and it's not something that that's commonly done. And from class, the way we classify types of economic evaluations is, is it a CEA, CBA, CUA, or CMA? But these studies don't necessarily conduct their economic evaluations in that way. So we had to classify them according to if it was comparative, and whether the input costs to operate the pharmacy program was included, and lastly, if economic outcomes were measured. So I'm just going to kind of briefly go through these different types of designs. And this was adapted from Drummond. So for cost descriptions, no, it's not comparative, and we only measure the operational cost of the pharmacy program. If it's an outcomes description, then again, non-comparative, we don't measure operational costs, but we do measure economic outcomes. If we measure operational costs and economic outcomes, but have no comparator, then it's a cost and outcome description. And return on investment could fall into this category, but that could differ as well. And analytic methods require that there is a comparator. So for cost analysis, we would have a comparator and compare operational costs of the two programs. Outcomes analyses is if we have a comparator and compare outcomes of the two programs. The gold standard, of course, would be if we measure both. We measure inputs and outputs and also compare it with some sort of standard of care or usual care. And from this, then we could calculate, incremental cost effectiveness ratios and, compare it with some sort of threshold to determine if something is cost effective. So the way we classify the economic evaluation, again, is just based on design type and not necessarily the details of the actual analysis. So what we define as high quality was if it was a full economic evaluation, so comparative and inputs and outputs measured. Medium quality would be our analytic methods in which we do have a comparison. So with a cost analysis, we could compare whether, implementing the pharmacy intervention is maybe cheaper than that physician intervention. And we could also compare outcomes and judge whether the pharmacy service provides more benefits relative to usual care. And, even though cost and outcome descriptions don't have a comparator group, we could see if whether the benefits outweigh the costs and make a decision on whether to implement that service or not. And then low quality studies would be our descriptive studies in which we only measure inputs or outputs and have no basis for comparison. So for those that were full economic evaluations, we attempted to, or we did, try to quantify their quality using what's called the QHES checklist. And the purpose of this checklist is to quantify the quality of CMAs, CEAs, and also CUAs. It's composed of 16 yes/no questions on specific criteria of the study. And each of those criteria is weighted based on its potential impact on the quality of the study. So for example, if a study utilized RCTs, then that would receive a relatively high weight of 8. And if they assess uncertainty in the form of sensitivity analysis, then it would get added onto it a point value of 9. So it's a scale from 0 to 100, where 100 would be the highest quality design. But it's in a yes/no format, so it's kind of more on a checklist. And if it's there, then you check yes, and then it gets the points. But it doesn't really truly assess the quality of the methods. Okay, so for CPS setting and classification, we included where pharmacists typically practice. So commonly that will be the hospital, community pharmacy, or ambulatory care clinic. The type of clinical pharmacy service, we also classified that according to several categories. So the common ones are disease state management, where the practice focuses on a single disease state, or diseases in a common class. So, a diabetes pharmacist or infectious disease pharmacist would fall in this category. General pharmacotherapeutic monitoring is kind of a catch-all, so pharmacists that manage several disease states and several medications. Other categories, targeted drug programs, so pharmacists strictly dealing with a particular drug class. Patient or provider education programs, wellness screenings, health screenings, and others that may not necessarily fit this classification scheme. So regarding the data analysis, it was relatively straightforward. It was just a calculation of proportions used to describe the study characteristics. For full economic evaluations, we assessed the quality using the QHES. And we didn't get to calculate it out, but we're going to attempt to pool these inputs and outputs that were measured and calculate a pooled benefit to cost ratio or an ICER, data permitting, of course. And then we also compared the data that we have to prior systematic reviews, and we were only able to go back to 2001 because prior to that, the classification scheme of studies was slightly different. Okay, so on to the results. So this was our condensed Prisma diagram. So title screening, about 17,000 articles, which went down to about 1,800 articles for the abstract screening. We had 973 manuscripts enter the manuscript screening phase. And then we had 209 manuscripts that met the final inclusion criteria. And we had, of that, we kind of had to split it up because, there was a lot of articles. So there were 110 studies based in the US and then 99 studies from other parts of the world, so Europe, Asia, South America. Yeah, mainly those countries. Okay, so now moving on to the results of the classifications. So if we look at the proportion of high quality study designs, which we've, so what we've categorized in here are experimental studies and interrupted time series. And we can see that it's only 3% of the total 110 articles that we've had. For the medium quality study designs, so the quasi-experimental designs, your observational studies would fit in here. Again, 23% of the 110 articles. And then the low quality designs, which would be our single group studies and 2 group studies, but use of a historical control group, accounted for over 50% of the types of studies or study designs. And then the true economic modeling studies accounted for about 7%, so 5% decision tree models and 2% Markov cohort models. And that 1% was a work sampling study, which we couldn't really fit into the classification scheme that we were using. And in regards to the type of economic evaluation and quality, so for the proportion of high quality designs, again, which would be, we're measuring inputs and costs and their comparative, it was 6% of the 110 studies. And for the medium quality studies, which would be our analytic methods, so comparative, and our cost and outcome descriptions in which we measure inputs and outputs but don't have a comparator group, these accounted for over 50% of the study designs or types of economic evaluations. And then lastly, the low quality study designs accounted for about 1/3 of the types of economic evaluations. Okay, so of those full economic evaluations, I've briefly summarized them here. So we can kind of just go through what types of interventions these are. So Irwin 2015 evaluated pharmacist osteoporosis management versus nursing management. Olvay evaluated a telephone MTM program, which is very popular nowadays. So pharmacists are in a call center, for example, for a health plan, and they're contacting their patients regarding refills or assessments of medication effects. Pharmacists managed ESA clinics. So ESA is erythropoietin stimulating agents, I think. Maybe the P3s could help me out with that. But again, for outpatients, patients with non-dialysis dependent kidney disease who are receiving erythropoietin agents. Pharmacist diagnosis and treatment of strep throats in the outpatient clinic. Pharmacist diabetes management. We have a big practice here at UIC for diabetes. Comprehensive medication reviews, which is kind of like MTM. And then pharmacist hypertension management versus usual care. And we can see that they're all based on decision models. And what I've highlighted green in the summary section is those that reported, a beneficial effect of that pharmacy practice. So for those studies, they reported that it was cost effective and in most cases were the dominant treatment. And dominant meaning that, the pharmacist practice, had additional benefits at a lower cost compared to the comparator. And on that last column there is a QHES score, and the average QHES score for these economic evaluations was relatively high at about 83. Okay, so now onto the proportion of service types. And you can see here that orange and blue pies account for, the majority of the distribution. And, 42% to general pharmacotherapeutic management, so that's kind of the catch-all category where pharmacists treat patients on, with multiple diseases and deal with multiple medications. disease state management at 28%, where pharmacists really focus on a particular disease state. And then targeted drug program accounts for 18%. So pharmacists that deal with strictly a particular class of drugs. And, with vaccination services now by pharmacists, wellness programs and immunization services account for 5% of these studies. And then patient education programs, which are defined as just education with no interventions, is at 7%. Okay, so where are these analyses being conducted? So the majority are, of course, in the hospital inpatient setting at about a third, and then next at the ambulatory care clinic, so outpatient services at 29%, and then community pharmacy is the next largest at 17%. And the other sites, there's 1% at the emergency departments, 3% accounted for multiple settings, and 11% were kind of this other category. And that other category is mostly composed of those MTM services where the pharmacist is at the call center and they're calling the patient at the home. So you couldn't really categorize that into any of these other categories. Okay, so trends in practice. So this is comparing the distribution of these study design, the type of service across time. So from 2001 to 2017. So as we can see in each bar, so it's a stacked bar chart. So like within one bar is the different types of pharmacy services. That in each year, what's accounting for the majority of distribution is general pharmacotherapeutic monitoring, disease state management, and targeted drug program. And these are, 5-year increments. At 2016 and 2017, that's only like 2 years worth of data, so that we may not have the entire picture there. And then for the setting of the service, again, we see a similar pattern throughout the years in that most of these evaluations are taking place in the hospital setting and outpatient setting, and then to some extent at the community setting. I'm going really fast. Okay, so now I'm at my discussion. So again, the way we've classified the studies, it was very broad, so we didn't actually look into the specifics of the studies, but just used the design to classify them. So low quality study designs accounted for 2/3 of the total study designs. Low quality economic evaluations accounted for 1/3 of total evaluations. But in looking at those full economic evaluations, the quality was relatively high, and those studies did report that clinical pharmacy services were cost effective. And maybe to kind of ask, well, maybe why is this happening? Why are the majority of study designs low quality? Is it a lack of training to conduct proper research, or do pharmacists not have as much opportunities as other researchers to apply for funding? Because of course your design of the study is somewhat limited to what you can actually do and the resources that you have. So again, among full economic evaluations, they were generally cost effective. Regarding the pharmacy services and settings, these evaluations primarily focus on pharmacists as specialists, so disease state management, targeted drug program, and then secondarily as generalist practitioners, so dealing with a multitude of disease states and multitude of medication classes. CPS services primarily take place in the inpatient and outpatient setting, which is great because we're moving more into this clinical area. But we have to remember that the community pharmacist is the most accessible to the general population. So should there be more focus in developing clinical services there, and then evaluating them and showing that they deliver some value. Overall trends from 2001 to 2017. So I'm going to compare this to the systematic review dating 2006 to 2010. And the first thing I want to point out is that the sample size for 2011 to 2015 was 25. And I think from 2001 to 2005, it was 93. So it went from 93 kind of down to 25, and then up again to 209, with roughly 50% being U.S. studies. So, with that rise, the proportion of descriptive study designs increased from 16% in 2006 to 2010. And then the proportion of full economic evaluations decreased from 72% in the last systematic review. But among the full economic evaluations, that QHES score increased from an average of 60.4 in the prior study to, it was like 83 in ours. Evaluation of CPS, clinical pharmacy service, continue to focus primarily on specialists and generalist services. Inpatient and outpatient settings continue to dominate these evaluations. And, last but not least is that, the practice of clinical pharmacy is continuing to gain traction, worldwide. And I know here at UIC, we have some initiatives in kind of, bringing clinical practice abroad. I think we have a focus on, Dr. Luo travels to Southeast Asia a lot. And over the summer, I think we have people from other countries come over here to kind of learn what we do. And in 2006 to 2011, 64% of the studies were non-U.S. and were primarily based, I think, in the U.K. And then 50% of the identified studies for this time period were non-U.S. And, just from a very qualitative judgment, they're primarily centered, again, in the UK, Europe, and also Southeast Asia, and also the Middle East. So that's where those studies are coming from. And some limitations of our systematic review. So again, fairly high-level classification of study design and the type of economic evaluation. We may not have identified all CPS interventions, although I like to think that we did, because we had all thousands of titles to go through. We made no attempt to search for unpublished work or unreported data, so there could be a bit of publication reporting bias in what we presented. So conclusions: quality of study designs and the type of economic evaluations were relatively low, but of full economic evaluations, the quality was relatively high, and they did demonstrate cost effectiveness for these pharmacy interventions. And then these evaluations continue to focus on pharmacists in the inpatient, outpatient setting delivering clinical services. And I think that's all I have. Yeah. So fairly close.
Questions? Yeah.
So in community pharmacy, one of the middle-ish terms is that a lot of the pharmacy services that provide now can be maybe or done remotely.
Mm-hmm.
And so some people think that one of the ways that you can advance pharmacy at the community level is to get able to bill for your clinical services. So what do you think, what evidence do you think is missing from what we support that we can bill clinical services?
That's a good question. So the question was, what are we missing to be able to bill for these clinical services? And that's a very good question. So I'm going to use like the inpatient setting as an example first. So in the inpatient setting, pharmacy interventions tend to be more cognitive. So it's recommendations, evaluating patient charts, communicating to the physician whether therapies need to be optimized or changed or even discontinued. And it's not like a procedure like as what a physician would deliver, right? So I think that's a challenge in billing for more of these cognitive services. But now in the outpatient setting, then it's different. Because when you go to, here at UIC, when you go to a diabetes clinic, when you go to the rheumatology clinic, when you go to the GI clinic, the person you could be seeing may be a nurse practitioner, but even a pharmacist as well. So when you're conducting, that evaluation and assessment and, refilling a prescription, then you're providing like this direct service to the patient because you are seeing them. So you could bill maybe, I think pharmacists can bill a facility fee for that. So I think what's missing may not necessarily be, evidence that we, have an impact, but it's more, I think, in the payment structure, the way you could bill. Yeah. So is that good? Okay.
Brian, why was there the dip? Why do you think there was this major, in their early period, there was a ton of studies, then you find there's a large decrease in the number of studies, and then it popped back up from 2011 to 2016. Why? What's going on?
So, I mean, there could be a lot of things that explain that. So, when you look at the overall trend from 1988, like that first one had over 100, and then that second one had quite a few, then 2001 and 2005, 93, then at 25, and then mine increased to 200. So one, I think, obvious thing is the movement outside of the U.S., where, in Europe, Asia, Middle East, there the profession is moving on to the clinical area, away from that kind of dispensing and compounding role. And, they may be facing the same challenges there, and where, if we're providing these clinical services, we need to demonstrate value. So then that kind of forces, a lot of these evaluations then are performed, and then we pick it up. But also, journals may be kind of restricting what they're taking in. So, if it's low quality, will it pass their review process?
3 out of 4 did.
Yeah. And then, so, was that the case for 2005 to 2010? And then did it become less stringent again from 2011 to 2016 with, I didn't go through specifically the types of journals that these were published in, but, they're not like JAMA or so. And then with the kind of explosion of like open access journals, which I know just from reading them, there's a handful that are from these open access journals, which may be less restrictive. So then that kind of, so they may always been, conducting these studies, but what has been being published, I guess. And with the open access journals, that could contribute to this large increase. Yeah. Yes.
Brian, to that point, a lot past years, a lot of focus has been given to provider status. And provider status for pharmacists to be able to bill directly or clinical government services. In order to attain that, a big question is, what is your value? What is your worth? So do you think maybe this explosion of studies, albeit some of them, lower quality, do you think there might be a relationship or correlation with the need to justify or show the value of our service in order to attain provider status?
So the question was, with our push for provider status, should we be, sorry, could you repeat the last part?
So, building on Todd's question, right? The question was, why are we seeing an explosion of studies, in this cycle versus this cycle, right? And so, do you think that maybe this explosion has to do with the need to justify more the value of our services to attain provider status?
Yes, I would say yes. So, given, as I said before, that, and the typical kind of excuses like we're paying too much for healthcare, and pharmacy services add to what we're already providing, and we need to demonstrate that, at the margin, that for the extra amount that we're paying for these services, that we need to be demonstrating benefits. And for provider status, of course, it'll be important to demonstrate, cost effectiveness and value. But then that's kind of in a way subjective, because then what's your threshold? And payers, health systems may have different thresholds as to what they deem to be value. And so that impacts or that limits the impact of these studies on helping support clinical pharmacy services to be reimbursed on maybe what a physician would be doing. Okay, I don't think I really answered that question.
I want to keep following along this
Yeah.
line before you go to Shukri. I know I saw his hand go up, but
Yeah.
I agree with Edith. I think that's probably a reasonable explanation. But then, are we being our own worst enemy by 3 out of 4 articles being low quality? I was going to use a different phrase, but I'll use your phrase, low quality, right? Where that doesn't help make a good argument to policymakers or other decision makers about the value of these services if the quality of the science that we're bringing them is not very good.
Mm-hmm.
Not a question, just pontificating.
Yes.
I think it might be a little, I'm sorry. Just going off the same discussion, might be a little unfair to Brian to be asking him what we did in previous analyses, although he did present what's sort of happening. But I think the biggest issue has to do with editorial policies of the journals. What I heard in the last time frame, 2011 and 2015, is that both pharmacotherapy and analytic pharmacotherapy were requiring a higher level of evaluation, higher level of evidence, better quality study for it to get published. And I think that was the reason for the dramatic drop in that period of time. And now we have those 5 new online pharmacy journals, and pharmacotherapy is split up into JACCP, although that probably doesn't affect this analysis so much. But there's JACCP and pharmacotherapy, so they have their own journal for pharmacy-related interventions. So I think there's been a dramatic increase in the number of evaluations being published. We didn't see a huge increase, actually probably a decrease in the number of full economic evaluations, even with this cycle. So I'm not sure it's related to policy so much as people are able to get their stuff published again in these online journals. But I can't rule out that it isn't policy. We didn't assess that.
But that should mean, and I don't remember if you said this, that should mean that that middle period when there were a lower number of studies, the study quality was higher. Was that true?
We had the same, percent was higher. We had the same number of full economic evaluations. It's pretty steady across the board.
Yeah.
There were fewer low quality papers published during that.
Markedly?
Markedly.
Because what Brian presented basically said 3 out of 4 were low quality.
For this one.
For this current
true of
era.
the ones going back like 2 and 3 analyses before, but for that one period where there's only 25, about 10 to 12 of them of the 25 were decent quality, higher quality papers, which means that all of the not so good papers didn't get published.
Yeah, but it doesn't totally
Doesn't
explain away the entire difference.
It's true.
But I mean, I just still think the point is we need to do better science to advocate for ourselves, right?
Well, and I think Lee and Glenn have been advocating for that. For Lee Vermeulen, who was on a lot of these previous ones, that's exactly what they were saying repeatedly. We have a letter. We had a letter to one of the editors talking about the quality of these documents. It's a pretty high medical talking about how low quality.
Yeah, we do a disservice to the work that pharmacists do by continuing to report low quality evidence, right? It doesn't help convince anybody that they should be paying for these services if it's just, oh, look, I'm going to describe what pharmacists do versus take a rigorous scientific approach to it.
But on the flip side of that, we're expecting our clinical faculty to be publishing. And when what they're,
Talk to Dean about that.
what they're doing.
Well, don't worry, it's the last one of the semester, so you're on the
So there's a need for them to publish. Now they're asking you for them to publish again online journal.
Right. It's perhaps the wrong set of incentives.
I wonder if a journal analysis
And we did a little of that for the last paper, and I think we're gonna be doing it again for this one. Problem is, we had to split this up, because we wanna get these results out, and there were so many, and we just didn't have the manpower to move it forward, that we split it up into US and international studies, whereas the past ones were combined, US and international.
Actually, after this wonderful conversation, let's end it on that.
Thanks.
No problem.
Thanks, Brian.
Thank you.